Hi everyone, I am Dr. P.V. Satyanarayanamurthy, consultant spine surgeon at KIMS Sunshine Hospital, Secunderabad. Today I will be taking you about the history and or examination of the spine. Examination of the spine, it falls into four categories, basically history taking, the PERSI, the inspection, palpations and neurological examination and special testing. Coming to the examination of the spine, the first and foremost is history taking. History taking, I kept the slide blank because it is very, very important. Very, very important because it gives you a lot of insight or into the complaints of the patients. Like, suppose a patient comes to you with some complaints, with the advancement of a lot of imaging techniques also, the history is very important to correlate the patient complaints with the imaging. Just don't think that an MR scan can tell you about all the complaints of the patients. Suppose many times it happens that the patient comes with a huge disc in the lumbar spine, but the history may be very different. He may not have pain, but he may have weakness, or the pain may not be correlating to the MR findings. Like sometimes, very commonly, you see that patients come with the back pain or radiating pain, and if you clearly examine, then you can see that it is not the spine problem, it can be a problem elsewhere, like in the hip joints, or sometimes any vascular problems. Like suppose there is severe radiating pain, your MR scan may be very much normal. If you don't, or it can show a minor disc, and if you don't examine the patient, it may be a some other complaint. I mean, some other finding, like it may be a vascular concern. If there is some arterial stenosis, it may be very commonly mimic neurological pain. So history also is very important because the way the patient comes to you, the way he tells his complaints, you have to listen to them. You should give at least 90 seconds or 2 minutes to listen to the history. Because he says typically that, doctor, I have weakness in my lower limb. But if you ask, he never had any pain or any radicular symptoms. That we should think whether it is a complaint from the spine, or it could be a simple neuropathy, or some other medical problems like Guillain-Barré syndrome or any transverse myelitis. So history is very, very important, and you should correlate the history, the clinical findings, and the radiographs or imageology, and come to a conclusion. So don't give less importance to it. So conclude, history is very, very important. So coming to the physical examination, is sets like inspection, palpation, the movements, neurological examination, and the special testing. So coming to the inspection itself can give you many ideas. Like suppose you stand at the back of the patient and check for the back, you can find, look for any swellings or cafe au lait spots or any hairy patches or birthmarks, because they tell you many congenital problems. Suppose if there are any cafe au lait spots, or like this one, cafe au lait spots, or this small coffee what do you call, spots over all the back, or you can have only very minimal, like big spots, 2 or 3 marks. These are the hairy patches. Many times you must be seeing these hairy patches, and these are birthmarks, or what you call port wine spots. See, cafe au lait spots represent any also look for any pedunculated outgrowths, like what you call as a neurofibromas. So cafe au lait spots and the pedunculated spots reveal that there is some neurofibromatosis. This hairy patch tells you about any underlying spinal pathologies, like congenital problems like diasteatomylia. Diasteatomylia is any what do you call, birth defect in the column, spinal column, not the spinal cord, spinal column. The spinal column can have cleft in the canal, spinal canal, which can divide the spine into two halves many a times. So that is very, very important. Also, we should look for any myelomeningocele or meningocele which are by birth you can the congenital problems. You can have swellings, like protruded swellings in the back. These port wine spots represent like spina bifida. See, hairy patch or a fawn beard is suggests of underlying spinal pathology, diasteatomylia. Birthmarks such as spina bifida is per se not a big issue, but it can be multiple types. If it is a significant one, then we can meningocele. These pedunculated tumors or cephaloid spots suggest neurofibromatosis. Why neurofibromatosis is important was because many times you see there are scoliosis which are neuromuscular scoliosis in neurofibromatosis. So, how to examine how to do a physical examination? Basically, you should look for the posture from the back. The patient you are seeing from the back, you should look for any deformities of the spine. Suppose this is the back of the patient, you can see whether the spine lies in between. If suppose you should look for the spine is curved in the upper back or lower back, what do you call in the scoliosis. You can see this many times. You can see this. I'll show you in a video presentation how it looks. Also from the side, look for lordosis. When you have normal lordosis around 30 to 40 degrees in the spine, usually if you see from the side, you can see there is from the back there is no deformity. I mean the spine is straight. If you see from the side, the spine has curvature. In the lumbar spine, you have a lordosis. In the dorsal spine, you have kyphosis, and again in the cervical spine, you have lordosis. That is how the balance is maintained from top to bottom. Also, see for any exaggerated lordosis, which represents high grade spondylolisthesis, and also any deformities. Deformities like if there is any kyphotic deformities in the lumbar spine or in the dorsal spine. The kyphotic deformities are very common in the dorsal spine, which say like this is a gibbous deformity, which is very common. Earlier days we used to see very commonly because of the rampant of tuberculosis. Nowadays these gibbous deformities represent mostly kyphoscoliosis or Scheuermann's disease or ankylosing spondylitis. Paravertebral spasm, if you can see from the side or from the back itself, you can see that there is a spine is very taut. It represents any injury or some infections, underlying infections. Also from the back, you should see heart-shaped buttocks will represent high-grade spondylosis. Also, you should look for the loin creases. The absence of them which represent high-grade spondylolisthesis. Also, if you see from the side, you should see whether the patient has the posture of the patient, whether the patient has any crouch gait or is he standing normally. Crouch gait represents any tight hamstrings, basically because of high-grade spondylolisthesis. So next will be the palpation. Doing palpation would be you should be sitting behind the patient on a stool and start examining the bony prominences. Basically, you should look for the iliac crest, the spinous process and the iliac crest. Also, palpate for the coccyx, which is not really necessary in many of the cases, and for the trochanters on the side and all the ischial tuberosity here. I will show you how to examine all these things. Sitting on the back of the patient, because the iliac crest blade represents the L4 L5 disc space. The iliac crest usually represent L4 L5 disc space. And also this posterior superior iliac spine PSIS represents this S2. S2 what do you call these are surface landmarks of this S2 is PSIS, the posterior superior iliac spine. You have to do this from when the patient is standing in front of you and so you are sitting on a stool. Also, while examining the palpating the spine, you should look for any steps in the what do you call the spinous processes. This August step off sign is commonly seen in listhesis. Also, when examining the spine, you should look for any curvature in the spine. If you are going from lower lumbar spine to cervical spine, from the back, if you see sometimes in scoliosis, the spine you can see that palpation will be. It may not be straight. The spine usually should be straight like that, but in scoliosis, you can see that there can be palpation may go. It will be crossing the midline and going across. So also check for the coccyx. Sometimes the patient may have tailbone concerns like coccydynia. Then you can check for the coccyx, and also palpate for the greater trochanter, which is on the side, and the ischial tuberosity while asking the patient to flex at this hip joint. The tenderness at ischial tuberosity may represent any tight hamstring spasm, tight hamstrings, which is very important. Sometimes the patient may have significant radicular symptoms, but when you see the spine may be normal, but there may be ischial bursitis or ischial, which can be examined while palpating the ischial tuberosities. So also check for the supraspinatus ligaments and supra and infraspinatus ligaments of the which are in between the spinous processes. These ligaments, suppose there is a patient has complaint or any injury, they can be very tender, those points. Also like check for any spasm of the paraspinal muscles. This is how you check for the paraspinal muscles. This is how you examine the greater trochanter. Sitting behind the patient, you can palpate the greater trochanter, because many times the patient may have back pain, but if you examine the complaint, maybe in the diagnosis may come as a OA of the hip. Usually simple thing is, if the patient complains of pain in the buttock, usually it is coming from the root stretch, that is any complaint in the lumbar spine. But if he complains of pain in the groin, that should usually goes towards hip joint. So you should take a proper history. You should ask whether the pain is in the buttock or in the groin. Once you are done with the palpation, then you go for the movements. This is not really very important in normal clinical scenario, but for your exam point of view, this you should be knowing. The normal movements of the spine, lumbar spine, or the flexion, forward bending, the extension, backward bending, and the lateral flexion and the rotations. So how you do examine all these things? This is how you do the physical exam. Range of motion, flexion, ask the patient to bend forward as far as possible with knees tries to touch the toes, and you should check the distance between the toes and the fingers bending. Also you can check the patient, strip the patient, and also mark the spinous process in the lumbar spine. Suppose you mark L5, L4, L3, L2, L1. Suppose you mark L1, L2, L3, L4, L5, and ask the patient to bend forward. Then you can see there is a stretch between there can be L1 can be here, L2 can be here, there can be a distance between the increased distance between the spinous processes. This is called as Schober's test, and there are modified Schober's test also. Not very clinically important for us, because you cannot do all these tests in the exam also. Very difficult to do all these things. But you should be better know all these tests, Schober's test and modified Schober's test. Once you are done with the flexion examination, then extension, you ask the patient to keep hands on the PSAs and bend back to see how much extension he has, whether he is able to do extension or not. So coming to lateral flexion, stabilize the iliac crest. Basically ask the patient to bend to left and to right, and check whether the both sides are equal or not, when right bending and left bending are equal or not. This is sometimes useful while examining the dorsal spine in case of scoliosis, where you can see for the flexibility of the spine. Suppose there is a scoliosis to right side, you can ask the patient to bend right and left, and you can see how much the bend is correcting. This is very important while correcting the deformity intraoperatively. Then you can see whether this curvature is flexible or rigid. Rotations also fix the stabilize the iliac crest and the pelvis, and turn the trunk this way by rotating the pelvis and the shoulder on either side. So coming to the most important thing is the neurological exam. Once you have completed your history, the inspection and the palpation, neurological examination is very important too, because this comes to a conclusion where the concern is. Like suppose where the patient, your examination can tell where exactly the problem is, whether the problem is in the cervical spine, the dorsal spine, or the lumbar spine. And at lumbar spine, whether it is between T12 to L1 or L2 or L34 or L45 or subsequently L5 as well. Coming to the neurological examination, basically first we need to look for the motor testing and the sensory testing. Neurological examination between T12, L1, L2 and L3, the motor test is for the iliopsoas, which is the hip flexor and the internal rotator, and the sensory test is like marked for the sensation in the gluteal region. This represents L1 and an anterior aspect of the nerve which represent L3. This is for L1, you see, this is for L3. The L5 stands for the shin part of the leg and also the dorsum of the foot. If you see L4 is the lateral aspect of the leg, and also if you see L2, this base comes from the gluteal aspect to the lateral aspect of the thigh, and S1 is the plantar aspect of the foot and also the lateral aspect of the leg and ankle, and S2 is completely, you can see, complete back of the thigh and leg. Coming to neurological examination of between iliopsoas. Iliopsoas is tested in multiple ways. One is by making the patient sit and ask him to flex the thigh or hip joint. Then this gives iliopsoas. I mean, anyway, you know that in the normal grading or 0 to 5 gradings. This is how iliopsoas is tested. And you as said, the sensory testing is done between groin area and the back of the buttock. So once you are done with iliopsoas testing, that is between T12, L1, L2 dermatomes or myotomes, then it will be the examination of the quadriceps and hip adductors, which represent L2, L3 and L4. So quadriceps examination you do by patient asking the patient to lie down and extend the knee joint, and hip adduction anywhere place the patient supine on the table and check for the hip adduction. Coming to the very common area is L4, which is more commonly affected. Most common affected levels are between in the spine is L3, 4, L4, 5 and L5 S1. L4 usually any compression, but L3, L4 can cause the symptoms at the L4 dermatome. So neurological examination level 4 lies with motor testing, which is for tibialis anterior, the sensory aspect with the medial side of the leg, and the deep tendon reflex or the patellar reflex. So how do you examine for the tibialis anterior? Ask the patient to dorsiflex the ankle and check for you can palpate the tibialis anterior and see whether how taut the tone of the tibialis anterior. Usually a patient with problem at L3, L4 or L4, 5 many times will have this weakness of the tibialis anterior. This is how you do this, what we call basically as the knee jerk or what we call patellar reflex, and sensation blunting will be there on the medial side of the leg and also middle aspect of the foot. Coming to neurological examination at L5 dermatome, L5 dermatome represents motor examination would be EHL and EDL. EHL is represents extensor hallucis language, which you examine by asking the patient to flex the or what you call extend the great toe. Extension of the great toe will give many times, and also suppose by chance there is amputation of great toe, you can examine for the rest of the toes L4, which will be extensor distorum longus. There is no L5 reflex, I mean there is no deep tendon reflex for L5, and the sensory level is marked at the dorsum of the foot. This is dorsum of the foot represents the L5 completely. Coming to neurological examination of S1 represents motor examination will be peroneus longus and gastrosoleus. Peroneus longus you examine by asking the patient to avert the foot and examine whether tone of the muscle. And the sensory would be the lateral and the plantar aspect of the foot. This is the lateral aspect of the foot, and also if you see the foot base of plantar aspect of the foot can be numb in case of, or they can have paresthesias in case of S1 root involvement. The deep tendon reflex is basically the ankle jerk, what we call basically as ankle jerk. Examination of the distal muscles like intrinsic muscles of the foot gives the dermatome level of S2 and S3. There are other sensory aspects where the intrinsic muscles of the foot give the motor level for S2, S3 and S4. The sensory aspect would be the anal reflex, what we call the 3 concentric rings around the anus. This is usually not tested, but in case if you feel that the patient is in has lost his bladder or bowel because of any lower lumbar lesion or upper motor lesions. This gives more idea about the recovery also. I mean, suppose now you examine the sphincters are not good or there is no anal reflex, then you have this will prognosticate the condition. Coming to reflexes, there are two kinds of reflexes: superficial and the deep tendon reflexes. The abdominal, anal, and cremastic reflexes or superficial reflexes requiring skin stimulation, and that is mediated through the cerebral cortex. The knee reflex and the tendoachilles reflex or the ankle reflex or the deep tendon reflexes and require tendon stimulation and are mediated through the anterior muscle, which represent the motor cortex, lower motor cortex. The DTRs or deep tendon reflexes are prevented by exaggerated reactions due to the inhibitory action in the cerebral cortex. In upper motor lesions, you see there is absence of superficial reflexes, but there is exaggeration of the deep tendon reflexes. In lower motor lesions, there will be absent tendon reflexes. Suppose there is lesion above D12, there can be exaggeration of deep tendon reflexes when knee jerk or ankle jerk. They can be brisk or exaggerated, what we say. Very commonly you see in cervical myelopathies or dorsal myelopathies, or if there are any tumors or any cord injuries or in infections like most commonly tuberculosis. And these element lesions, absent deep tendon reflexes, commonly seen in this cord equivalent syndromes or any disc pathologies in the lower lumbar spine. How do you examine for the abdominal reflex? Abdominal reflex has three quadrants between T10 to T12, T12 to T10, T12 and L1. This represent the, suppose you stroke each quadrant of the abdomen, the umbilicus should move towards that point being stroked. If there is absence of that stroking, then you can quantify that the lesion can be at that level. Cremastic reflex is by stroking the inner side of the thigh, where you can see the scrotum is pulled up, or there can be contraction in the scrotum. It's not regularly done in your outpatient clinics, but in clinical, in your examination point, this should be very much known. And the other one is anal reflex. Pinch the anal skin, and the external the sphincter will contract. That the most important examination what you need to do in your clinical examination or in your examination is you should know about this bulbocavernous reflex. This one bulbocavernous reflex is very important in your clinical practice also. Suppose a patient comes to you with a severe radiating pain and complains that he has no control on the bladder and bowel, then you will have to examine for the for his sphincters, which is most common. The bulbocavernous is most commonly done. It is how it is done. You do a per rectum. It's a per rectal examination, and if the patient is catheterized, try to pull the catheter. Once there is a pull in the once you pull the catheter, the anal muscles or anal sphincter should contract. There should be a contraction of the anal sphincter. If the anal sphincter is contracting, that means there is no significant lower motor lesion that lower down the spine, that S1, S2, S3, not S1, S2, S3, S4 are not involved. Suppose there is no contraction of the anal sphincter, then you should clearly said that bulbocavernous reflex is positive, and it should be mentioned, because once recovery of this bladder or bowel depends on the recovery. Once you feel that this anal sphincter is not contracting, then you can clearly tell that this is a significant cord equivalence syndrome, where you, this has very much medico-legal aspect also. If you don't examine this and the patient complains that later after your spine surgery or whatever it is, if you are suppose operating the patient never regains his bowel bladder, and if you are not examined for this, then it can pose a problem. So bulbocavernous reflex is very important. So how do you do? For suppose if the patient is catheter, it is very easy to pull the catheter, but in case for a male patient who is not catheterized, you have to pinch the glans penis. But for female, ideally better catheterize and do the testing. The final reflex would be Babinski test. This is done by stroking the plantar surface of the foot on the lateral aspect from the from the calcaneum to the base of the along the medial border to the base of the greater toe. You have to look for the great toe and also the rest of the toes. If there is a fanning of the toes and extension of the greater toe, then the Babinski sign is positive, which represents there is a UMN lesion, upper motor lesion. This is very, very important sign which you have to elicit in upper motor lesion. Suppose you examine the spine, Babinski sign is positive, then you have to consider examining for the dorsal spine or the cervical spine. This is how normal is this negative Babinski sign or normal sign, and this is abnormal sign. Abnormal spine is the extension of the fanning and extension of the toes. So coming to special test, these tests are done to any stretch on the spinal cord. There are few special tests like SLR or straight leg raising test and well leg raising test, Hoover test and Kernick test. Well leg raising test is also called as cross SLR test, SLRT. SLR, I mean, I'll tell you what it is. Hoover test and Kernick test are other tests, and also you should check for you should do a milligram test and Valsalva maneuver to check for the intrathecal pressures. And also the special test to check for the sacroiliac joints like the pelvic rock test, Ganslin test, or Patrick's or Fabry test, Fabier test, flexion, abduction, external rotation examination. So coming to SLRT or straight leg raising test, this is a passive test. This is not an active test. You should not ask the patient to lift the lower limb. This is purely a passive test where you should stand by the side of the patient or in front of the patient lying supine, and you should stabilize the knee joint. You should not allow, ideally your hand should be on the thigh and raise your lower limb, raise the leg. And once you are doing, the patient complains of pain or the radiating pain along the back of the leg or the thigh, then you should mark that level. Suppose if the patient has the positive test at 40 degrees, suppose, stop there, come to 30 degrees, dorsiflex the foot, and then you see that again he can have pain. That is one test which will represent the stretch on the final roots. In a well leg raising test, suppose the patient complains of pain only on the left lower limb, left radiculopathy, but once you start doing SLRT on the right side, the patient will complain of pain in the opposite leg, that is on the left leg. This is also called opposite leg or positive cross leg raising test, what I said earlier as cross SLR. This is more significant. Suppose cross SLR is positive, then you should consider there is a significant compression in at the root level, spinal roots. So this is another test called Hoover test. This test is done to detect the malingering when the patient is doing the SLRT, but sometimes the patient may do malingering. The patient is genuinely raising the leg. He puts the pressure on the opposite leg or the calcaneum, and then you can check. Suppose you are lifting the leg, both the legs. If there is a positive on one side, he tries to press the other side down, because that gives a lot of stretch there. Testing for the sacroiliac joints or pelvic rock test, there are 4 or 5 types of tests in this. Place your hands on the iliac crest and thumbs on the ASIS. On the iliac crest, the hands are here, the thumb on the ASIS. Compress the pelvis towards the midline. If there is a pain at the SI joint, that shows it is a positive sacroiliitis. Also, there is one test called Ganslin test. This is how it is done. patient supine and drop both the legs to the abdomen. I mean, put the legs to the abdomen like this. Then bring the patient to the edge of the table and drop the other leg down completely. If he experiences the pain in the SI joint or the back, then this is a positive test. Ganslin, this is called Ganslin test. The other one is a very important test, is a quick test which you have to do in your clinic, is the Faber test. I mean, Patrick Faber test. In this, very quickly, once you are done with SLR, then you have to just do a figure of 4. That gives you a lot of idea whether the patient has any complaint in the, it quickly rules out any complaint in the spine or in the hip or in the sacroiliac joint. The hip joint is flexed, abducted and externally rotated. That is what is Faber test. Flexed, abducted and externally rotated. This is what is Faber or Faber examination. This is what flexion, abduction, external rotation examination. To stress SI joint in the same position, place the hands on the knee and opposite ASS and press down. The pain at the SI joint is very important. Also, I mean, as I said, your lumbar pain can be from the hip joint or from the rectum or also pelvis. So your examination give lot of insight. Just you cannot rely on your imaging many times. Many times you can, many times in the sense, at least if you lose, you can find out one in your another examination. That is very important. Many times you see in your clinical practice, the patient come with the severe back pain, and also on examining you can see the patient has pain in the sacroiliac joint. There can be sacroiliitis or there can be hip osteoarthritis. I mean, nowadays you're commonly seeing post-COVID, there are a lot of AVNs. The patient may present with the pain in the back, but it can be from the hip or the sacroiliitis. It is very common. You can, it is nothing like if you don't examine, you are likely to miss it. So, mind you, the physical examination is as important as your imageology, and your physical examination should be always be correlated with your history, the clinical findings and your neurological examinations. Thank you.